Hello everyone and welcome back to Barium series. In this chapter, I'm going to teach you about barium meal. So in the field of radiology, barium meal plays a pivotal role in the examination of upper GI tract. It is a contrast administered radiographic examination of primarily stomach but also the distal part of esophagus and the proximal part of duodenum. Okay, so in the following slides, we'll explore the procedures of barium meal studies, its indication, contraindication, various projections, and its applications. Okay, so today we'll be talking about, we'll start with anatomy of stomach, then indications and contraindications for doing a barium meal study, then how to prepare the patient for a barium meal study, the contrast media used in it, and most importantly, the standard view. So this one is a bit difficult to digest, but I'll clearly explain that to you. Now, after that, we'll discuss the single contrast study and double contrast study and the complications and aftercare after we have done the barium meal study. And also, we'll discuss some case studies. Okay, so with that, you will be able to identify how the barium meal study appears for different conditions. Okay, so let's dive into the anatomy of stomach. So here is a picture of stomach. You know, stomach is a J-shaped muscular organ which lies in the upper abdomen. It extends from esophagus to duodenum. Okay. Now, the parts of stomach are divided mainly into cardiac, fundus, body, and pyloric antrum and pylorus. Okay, so I'll show you each one correctly. So the first part, which is continuing with the esophagus, is cardia. Okay, so this small part is cardia. Then the upper part here is the fundus. Okay, so this is fundus, and this biggest portion is known as body of the stomach. Okay, so this one is the body, and we have pylorus, and this is the pyloric antrum. Okay, this one is pyloric antrum, and this one is pylorus. Okay, so this one continues as pyloric canal, and duodenum starts after that. Okay, so these are the main parts of stomach, that is cardia, fundus, body, antrum, and pylorus. Okay, now other than these parts, stomach has two curvatures. Okay, so one here, this smaller one is the lesser curvature. Okay, this is the lesser curvature, and the one on the outside portion which outlines this side is the greater curvature. Okay, so these are the main things you have to know about the anatomy of stomach. Okay, also stomach has two sphincters. Okay, sphincters are present where there is a junction is present. So stomach has two sphincters, one on the upper side which controls the gastroesophageal junction, that is the gastroesophageal sphincter, and also one down here, that is the lower gastric sphincter. Okay, so these are the two sphincters of stomach. So again, stomach is a J-shaped muscular organ, and it lies between the esophagus and duodenum in the upper abdomen. And on which side does stomach lie, on the right side or left side? Left side. The stomach lies on the left side of the abdominal cavity, caudal to the diaphragm at the level of T10 vertebrae. Okay, so stomach lies below the diaphragm at the left side and at the level of 10th thoracic vertebrae. Okay, so the extent and the landmark should be by heart to you. Okay, so at which level? Level of 10th thoracic vertebrae. And the parts of stomach are cardia, fundus, antrum, and pylorus. And it also has two smooth muscle sphincters. which I told you. Okay. Now let's look into the blood supply of stomach. So where does stomach get blood supply from? What are the arteries that supply stomach? They are firstly for lesser curvature, the right gastric artery and left gastric artery will provide blood supply. Then for cardiac part, the left gastric artery will provide blood supply. And coming to the greater curvature is perforated by right gastroepibloic artery and left gastroepibloic artery and short gastric arteries. Okay. And finally, fundus of the stomach is perforated by short gastric arteries. Okay. So just remember these arteries and which one supplies which parts. Okay. So mainly we have right gastric arteries, left gastric arteries, short gastric arteries, and right and left gastroepibloic arteries. Okay. Now the other important anatomy of stomach is stomach wall is made up of mainly 4 layers. Okay. So these 4 layers are from the inner side. I am talking from the inner side to outer side. Okay. So the one which lines the lumen of stomach, that is the innermost layer, is mucosa. Okay. So it is in this mucosa that the gastric glands all are present. Okay. So here is a green colored structure marked. So it's a gastric gland. And after that we have submucosa. Okay. So the one coming right after mucosa is submucosa. Okay. Then we have muscularis layer. So this one is the muscularis layer. So muscularis layer is again composed of 2 types of muscles, that is inner circular muscles and outer longitudinal muscles. Okay. And finally we have serosa. Serosa is the outermost layer of stomach wall. Okay. It has the blood supplies and all. So this is the basic histology of stomach. So now let's come into the various indications where we go for a barium meal study. So first one is epigastric pain suggestive of peptic ulceration. So if a patient is suspecting peptic ulceration, then the patient will be complaining about the epigastric pain, that is pain in the stomach, like a kind of burning pain. That is mostly felt on an empty stomach, and also in the night time after having the meals also this pain will be present. So this kind of pain, a gnawing pain will be present in the case of peptic ulcers. And the second indication is anorexia. Anorexia means it's a condition which is characterized by the patient will have weight loss, because the patient is somewhat feared of getting overweight and all those notions. So the patient will be having a very low diet and it results in weight loss. And then we have failed upper gastrointestinal endoscopy, or patient unwilling to undergo endoscopy. So in some patients they won't be comfortable doing the endoscopy procedure. Okay. Or sometimes it won't be we won't be able to perform endoscopy in some patients. So in that case barium meal is an alternative to endoscopy. Okay. So in such patients also we will do a barium meal study. Then vomiting can be indicative of many diseases. So to rule out the diseases we can suggest a barium meal study. Then we have anemia, heartburn, dyspepsia. Dyspepsia is another clinical name for indigestion. Okay. So in this case also there will be burning pain, and also for all these cases we do barium meal study. And some other indications are upper abdominal mass. So if we are suspecting some benign or malignant lesions, then also we can do a barium meal study. Then gastrointestinal hemorrhage. So suppose there is some internal bleeding occurring from the gastric or intestinal tract, then in that case also we can do a barium meal study. Then gastric or duodenal obstruction. So if any obstruction is present, or in order to look for any obstruction, it's in a suspected case, then we can do a barium meal and find out if there is any obstruction present or not. Then malignancy of gastroesophageal junction, stomach, duodenum. So in case of any suspected malignancy of any part of the GIT, we can go for a barium meal. Then motility disorders of gastrointestinal tract, and in children to identify the cause of vomiting. So vomiting can be, as I said, indicative of many diseases. So in children, if they are having vomiting, then we can look for gastroesophageal reflex. Okay, so vomiting can be an indication of gastroesophageal reflex or pyloric obstruction, malrotation. So in order to rule out the cause of vomiting, we can look for a barium enema. So here is a picture of stomach cancer, that is malignancy of stomach. And yeah, here is an example of esophageal reflex. So that is there is some abnormality in the sphincter functions and all. So usually whatever is coming to down to the stomach, fluid or any content, it should continue to go down the stomach through the intestines and all. But in the case of reflux, what happens is whatever the content that came into the stomach is pushed upwards, it is going upwards. So that is known as the reflux. So once the food has come into our stomach, then the gastroesophageal sphincter should be closed. If it is open, what happens is the food will go upwards. Okay, so this abnormality where gastroesophageal reflex is happening can be clearly seen on a barium meal. Okay, so these are the indications for doing a barium meal study. Now, of course, there are some contraindications for barium meal. They are suspected case of gastroduodenal perforation. So perforation is a usual contraindication for barium studies. Okay, since barium is toxic when it comes out of the stomach or out of the peritoneal cavity, then it can deposit in the tissues and cause dangerous diseases. So that's why perforation is an absolute contraindication for barium studies. Okay, in which contrast we use barium as a contrast agent. Now, history or suspicion of aspiration. Then large bowel obstruction. That is a known case of a large bowel obstruction is present. Then we don't do a barium meal study. Then fistulous communication. If any fistula is present, then recent biopsy from GIT. So any recent biopsies were taken, tissues were taken from the gastrointestinal tract. Then also it is barium meal study is contraindicated. And finally, pregnancy. So we can't do a radiographic study using X-rays for a pregnant patient. Now, what is the preparation for a patient who's instructed to do a barium meal study? Do they have to prepare beforehand, or they can come as usual? They definitely have to go for some preparation. Like before the examination starts, they have to undergo 6 hours fasting. Okay, normally 6 hours fasting is instructed but advised. But in case of diabetic patients, as the prolonged fasting is harmful for them, then we can fix a morning appointment, or we can advise the patient to at least come on an empty stomach in the morning. Rather than fasting for 6 hours, just empty stomach on morning can do fine. Then another preparation is restrain from smoking. Okay, so if you have a barium meal study coming, then restrain from smoking. Then informed consent. So once the patient have come to our department with following the NPO, that is 6 hours fasting and constrained from smoking, then what we have to prepare next is we have to explain the procedure, and we have to rule out the histories, allergies and all, and we have to take the informed consent. Okay, so once all these are the preparation we have to do, once we have done all this, then we can start the procedure. Now the contrast media. So what is the contrast media used in single and double barium meal studies? So for single contrast study, what we use is low density barium suspension, around 80 to 100% weight by weight. Low density barium sulfate is used. And for if you are using high kV technique, then only 30% weight by weight suspension is enough for a single contrast study. In case of double contrast study, we know that for double contrast study, we will need high concentration of barium sulfate solution. So around 200 to 50% weight by weight volume barium sulfate solution is required for a low viscosity barium suspension is required to produce best mucosal coating and hence detail. Okay, so for a single contrast study, what we used was low density barium suspension, whereas for a double contrast study, what we used is high density barium suspension, which is also low viscosity. Okay, so that's barium studies. Now for each part there are some standard views. Okay, so in order to avoid the confusion, I've tabulated that here. So if we are looking for fundus part of stomach, okay, so now let's come into the most important topic part of today's topic, that is standard views for both single contrast and double contrast study. So just give some attention here so that you can identify it in a simple manner. Okay, so for that, first you have to visualize stomach in your imagination. Okay, so if we turn the patient to one side, which part contrast flows to which part, which side is enhanced like that, you have an imagination. Okay, so for first part is in order to see fundus, how do we have to position the patient? Just positioning the patient supine itself will give you a good image of a fundus. Okay, so this is how stomach is located in our body. Okay, so if we lie down, we can see the fundus part in supine view, that is the anterior view only. We can see the supine part. Okay, and if you're going for a double contrast study, then we can also have an erect with two views perpendicular to each other. That is, first we can take an erect AP, then we can take a erect lateral or a prone right side down view also. Okay, that is RIO view. Okay, so for fundus, the standard views are supine. For single contrast study, that is supine, and if you are doing double contrast, then we can do an erect AP, lateral, and supine RIO, prone RIO. Okay. Then if we are coming down to body, so we want to see the body clearly, we can do an erect or supine, erect or prone position. Okay, for a single contrast. Then for double contrast, we can place the patient in a supine position with 60-degree head end elevation. Okay, head side is elevated 60-degree. Then for antrum and pylorus, now look, fundus was located on the left side itself, but antrum and pylorus are slightly obliquely and also to the right side, right? So it is coming towards the right side. So for that, we can do a prone right side down position, that is RIO position. Okay, lying down RIO position for single contrast. And if you are giving double contrast, then we can also do a right side supine right side up also. Okay, then if you are looking for the duodenal part, that is first part of duodenum and that C loop, second and third part, then also we have to do a prone right side down position. Okay, so that the contrast will flow to the right side from the left fundus and parts, the contrast will flow down to the right direction, that is D1 C loop and all. Okay, now if we are doing a double contrast study, same supine right side up view also. And finally, if you are looking for the last part of duodenum, that is the D4 part, then we can position in a supine view. Then for double contrast, we can give a prone right side down position. Okay, so this is the standard views. Okay, we can go for additional views for further mucosal coatings and all, but this is the standard view. Okay, so for fundus it is supine, and for antrum and pylorus it is RIO, prone right side down position. Okay, now So let's start with single contrast study. Okay, so first what we do is we'll do a preliminary filling. Okay, so in erect position we can just do a fluoroscopy so that we can screen out the chest part, look for the thorax and lung apices and all. So to rule out that, we can do a preliminary study. Then next we can give the barium sulfate suspension orally around a 10 to 15 ml of 80 to 100 percentage weight by weight barium sulfate solution is given orally. Okay, then we'll start the fluoroscopy of the uh, contrast. Okay, so now what we do is we'll make the table horizontal and we'll make the patient lie down supine. Okay, so a patient is now lying down supine, and then what we do is we'll rotate the patient. Okay, so from a lying down patient, we are rotating the patient. Right side goes up. In this way, we'll rotate the patient in a clockwise manner. Okay, so why are we doing this rotation? So that we'll get a good coating of the entire stomach and the mucosa. Okay, so within that this itself, if we get a good mucosal coating, then we can stop the study. Okay, but suppose we didn't get a satisfactory image, that is there is some inadequate coating, then we can go for a further contrast study. So we'll roll the patient again in the same clockwise direction, and then we'll keep the patient supine, and around 100 to 250 ml barium suspension is given again. Okay, then spot films of the filled fundus in varying obliquity may be obtained in case any abnormality is detected. So after lying the patient supine position, we'll take spot films for the fundus. Then the patient is turned prone, oblique right side dependent, that is RIO position. Then in this position, the barium will enter into the duodenum, right? So through the antrum and pylorus, the barium will enter into the duodenum, and we can take spot films for the duodenal bulb and the C loop. Then again the patient is turned supine. Okay, so now we have taken the spot films of the duodenum. We'll ask the patient to lie down supine, and we are making the table erect again. Okay, from the supine position we are making the table into standing position, and then we'll take spot films for duodenal bulb and C loop again. Okay, in the right anterior oblique position, and we can also take some compression films also, gas compression films also can be taken. If we want to distend the stomach wall again, then we can give some more barium. Okay, if the image which was acquired is still not satisfactory, then we can give more barium and do the procedure again. We can also give graded compression in order to see the mucosal folds also. So so the thing is, patient is rotated so that all the margins are correctly visualized in the fluoroscopy. Okay, so I hope now you got an idea about the single contrast, right? Okay, it's nothing, just first we'll take a preliminary film, then we'll give the barium, then we'll take a supine view, then we'll take a right anterior view, then we'll keep on rotating, and we'll acquire the films, and once the adequate coating is obtained, we can stop the study. Now the advantages of single contrast studies, this is the optimal study for immobile patients and those who are unable to swallow the effervescent powder or tablets. Okay, so for patients who are immobile, and also for patients who cannot swallow the gas producing tablets, then a single contrast study is the best one. So that because for double contrast study we need the patient to swallow the gas producing agents, right? So if they can't do that, then only the available one is single contrast study. Then this is best for visualizing the pylorospasm, that is a spasm of pylorus, and this is also best for seeing the enlarged gastric rugae. Okay, so single contrast study can enlarge the gastric rugaes. Okay, then filling defects due to large masses in the pyloric and duodenal regions are identified easily. So there are filling defects due to the masses. So this can be easily identified with the help of single contrast studies, those filling defects which are seen in the pyloric and duodenal region. Then this is the procedure of choice for patients with gastric or duodenal obstruction. Okay, so if some patients has gastric or duodenal obstruction, then this contrast single contrast study is the best one. Okay, so that's all the advantages of single contrast study. Now there are some disadvantages also. So the disadvantages are some parts or some points can be missed, like small erosions, small linear ulcerations, and superficial gastric carcinomas, and subtle there can be some subtle mucosal abnormalities which are also missed. So since these three structures or indications are missed, these are some advantages of this single contrast barium meal. Okay, so remember this also. So now let's look into the double contrast barium meal. Okay, so since the single contrast barium meal has some limitations, we look for a double contrast barium meal. So this was mainly performed in Japan because there was increased gastric malignancies. Okay, so the main purpose was to screening for gastric tumors. Okay, double contrast barium meal is mainly used for screening out the gastric tumors. Okay, that too for early detection. Now, this double contrast study, it relies less on fluoroscopy and more on filming. Okay. Now, the preparation. So, unlike single contrast media, we have two contrast agents here. We have one barium sulfate suspension, and we also have a gas producing agent. So, which is the contrast agent that we use for double contrast study? We use a high density, low viscosity barium sulfate solution, that is a 200 to 250 percentage weight by weight barium sulfate solution. And then the contrast then we also use a gas producing contrast agent. So the gas producing contrast agent is sodium bicarbonate and citric acid are given orally. Okay, so when we give this orally, when they reach in the stomach, they'll produce the carbon dioxide gas. Okay, other than this two contrast agent, we also give another agent, one pharmacological agent, that is smooth muscle relaxants. Okay, so these are you might have seen buscopan tablets in the fluoroscopic room. So buscopan tablets, they are smooth muscle relaxants. Okay, so their function is to produce good distension in the stomach wall or bowel wall and produce the effacement of mucosal folds. Okay, so the chemical name of buscopan is hyoscine. Okay, and how much can you give to a patient? The dosage is 1 ml of buscopan intravenously. Okay, so these are the contrast agents. And when we come to the preparation, so before giving the contrast agent, what are that we have to look for in a patient? The patient's stomach should be dry and free from the secretions. Okay, so there our stomach might contain any secretion. So if you are doing a double contrast study, then there should not be any secretions existing in the stomach. Okay, so that's about preparation and contrast media. Now let's come into the different steps of double contrast study. So first, what do we have to do? We have to put the patient in a erect right anterior oblique position. Okay, then we'll inject the buscopan intravenously, and then gas forming agents are given. Okay, so remember that while we are doing a double contrast study, what we give first is the gas forming agents, the effervescents, then we'll give the barium. Okay, so gas forming agents are given, then double contrast film of lower esophagus. So first we'll take the double contrast film of a lower esophagus. We can start with esophagus. Okay, then we'll make the patient supine. Okay, now we are making the patient supine, and we'll ask the patient to roll in a clockwise manner from side to side. Then we can acquire the stomach spot films like fundus and all. Then a patient is put in right anterior oblique position. So why we are putting in this position? Obviously for the duodenal antrum pylorus region. So we can next take the duodenal contrast films. Okay. Then lastly we can give some table tilt, that is 30-degree table tilt, to attain maximum distension of the stomach. Okay. Then we can also acquire the mucosal relief films. Okay. So this is the outline of how you have to do a double contrast barium meal. Okay. Now, what are the advantages of double contrast over single contrast? This can provide you an accurate method for the assessment of post-gastric surgery. So, if any patient have undergone any gastric surgery recently, and we can do the barium meal in them as a post examination, then this is also the accurate method for looking for bile reflux, gastritis, then marginal ulceration, then recurrent carcinomas, abnormalities in the efferent loop. So for all these cases, double contrast barium meal is the preferred way, most accurate way. Okay. Still, barium double contrast study has some disadvantages. They are, a double contrast barium meal can miss some polyps. Okay, it can also miss some ulcers, erosions, and superficial carcinomas. Okay, so these are the disadvantages of barium meal double contrast study. Now, now that we have discussed single contrast and double contrast, their advantages, disadvantages, and all, uh, there are some complications for all these barium studies. There are some risks associated with doing a barium meal study. So what are the possible risks? First one is peritonitis due to unsuspected perforation. Okay, so we know that if a patient is having perforation, then it is a contraindication to do a barium meal study. We won't do a barium meal study. But suppose there came a situation where we weren't aware of the perforation, there was some unsuspected perforation, then and we did a barium meal study. What happens is it will cause a chemical peritonitis. Okay. Then second one is aspiration. You can see in this image that the barium has aspirated into the lungs. Okay. So barium aspiration is a possible threat to doing a barium meal study. Then side effects from the pharmacological agents used. So like the muscle relaxants and other type of pharmacological agents that we use along with the barium meal study can cause some side effects. Then acute gastric dilation. So it is a clinical condition which is a risk factor for complication. Then barium embolization. If a bleeding ulcer is present, suppose a bleeding ulcer is present, then barium embolization can be present. Barium embolization means stopping the blood flow due to this barium. Okay, so these are the possible complications while we are performing a barium meal study. Okay, so after we have completed the whole barium meal study, we can give some aftercare advices to the patient. Okay, before the patient leaves the hospital, we can give some advices like warn that their bowel motion will be white for a few days. Okay, so just inform the patient that their bowel motion can be white colored for the few days because they have ingested the barium. So we can avoid the unnecessary worry of the patient. Then keep his bowel open with laxative to avoid barium impaction, which can be painful. Okay, so we can provide some laxatives. Okay, so the barium will go out soon, and there won't be any barium impaction. Then we should not leave the department until any blurring of vision has resolved. Suppose if the patient complains that they have some blurring in their vision, then we shouldn't leave the patient alone in the department. We have to wait until the patient is fine with the vision. Okay, so these are the aftercare you have to follow. Okay, so with that, I guess you now have a whole clarity about the barium meal study, where it is done, how it is done, the different methods. Let's have a look into some case studies. Okay, so first one is a case study with normal findings. Okay, so this is a typical example of a barium enema with normal findings. You can see that the contrast flows through the stomach, flows through the esophagus and through stomach, and it reaches the duodenum, and it flows smoothly through this without any hindrance. And also this is a representative of barium meal, showing a healthy normal upper GI tract. Okay, so this is how a normal GI tract looks like. Now let's come into another case. So here you can see some abnormalities, right? So this is case 2, presence of esophageal stricture. Okay, so in this case, Barium study reveals that there is a construction in esophagus. You can see some construction here, right? So this construction is known as esophageal stricture. So this is a normal case that we have been seeing in our department, presence of esophageal strictures. Okay. So in this case, the narrowing of esophagus can be seen as a significant impediment to the smooth passage of barium. Okay. Rather than flowing smoothly, there is some impact onto this. Okay. So this is the gastric sphincter, esophageal sphincter. Okay. And another common example is hiatal hernia. Okay. Before I show you a barium picture of hiatal hernia, you have a idea about what is hiatal hernia. So this is the diaphragm, and usually where is the stomach present? Stomach is present beneath the diaphragm, right? In the left side below the diaphragm. But in case of hiatal hernia, what happens is through the esophageal hiatus, some contents of the stomach has gone upside, that is above the diaphragm. This is the clinical pathology of the hiatal hernia. Okay, so this is a usual finding on our barium meal study. So this case study here highlights the presence of hiatal hernia, where the part of stomach protrudes into the chest region through the diaphragmatic opening, that is the hiatus. Hiatus means simply an opening through which some part can come outside. Okay, so this is how a diaphragmatic hiatus hernia looks like. Okay, so the normal contents of stomach should be here, lying here, that is below the diaphragm, but here the contents are above the diaphragm, right? So this is a usual condition that we come across in our department. Okay, so I guess with this we can conclude today's topic. So before we conclude, let's just have a quick recap of what we discussed in today's topic. So what is barium meal study? It is the examination of our upper GI tract, including the distal part of esophagus, the whole stomach, and the proximal part of duodenum, with the help of a contrast medium. And what was the contrast medium that we used for this barium meal study? For single contrast, we used low density, 80 to 100% weight by weight barium sulfate suspension, right? And for double contrast barium meal, what did we use? We used high density, low viscosity, 250% weight by weight barium sulfate solution along with the gas producing agents. Okay, so that is a broad outline of a barium meal study. Then so the thing is, barium meal studies are invaluable tools in the diagnosis of the upper tract disorders, and they offer several advantages, including the ability to provide dynamic functional assessments and identify the abnormalities that might not be detectable with other imaging modalities. So barium meal plays a pivotal role in the diagnosis of upper GI tract diseases. Okay, so if you have any doubts or if you need any further clarification or explanation, feel free to reach out to me. So thank you for your attention and time. Thank you.